Just a quick reminder that on Monday we finished chatting about different types of hypersensitivities. Well, we started with one, okay. Now we're going to talk about hypersensitivity type 2, which you've already learned about because we discussed the blood groups. Okay? So hypersensitivity type 2 will be the transfusion reactions. I'm not going to cover the blood groups again. Yes?
I'm sorry, I have a question I don't want to forget to ask.
Sure.
For the Roman numerals, are we going to have to memorize the Roman numerals, or are we just for the factors? Or are we...
Oh, you can write Arabic. I'm fine. You can write like regular 1, 2, 3, 12, 11. No, I'm good. I mean, that's... Although, it's very easy. Roman numerals. 1, 2, 3, 5, letter V. 5 without 1 is 4. 5 with 1 is 6, 7, 8, 10. The X is 10. That's how they generate it. That's not the mnemonic rule. That's how they generate it. That was 2 palms. They give you X. That's 10. Although I don't know why L stands for 50. And come on, you can learn the number of the Super Bowl, which is written in Roman numerals, but you can't memorize Roman numerals for coagulation cascade? Give me a break. So you know that it's 50 or 51, but okay, transfusion reactions, quick reminder. You have a red blood cell with the, say, A antigen on its surface. If you pour it into somebody's with a blood type B, which type of antibodies this person is going to have? A, right, anti-A. So you have anti-A antibodies. Antibody binds to the antigen, and you've got agglutination of cells, lysis, and what's going to be the consequences of lysing red blood? Agglutination, clamping of red blood cells and breaking them in pieces. What are the consequences? If your red blood cells get all in the clumps, clot refers precisely to clotting, to platelets. It's going to be obstruction of flow, right? What else? The lysis, red blood cells get broken down. Hypoxia. Bless you. I mentioned before that hemolysis, the red blood cell lysis, if those cells go to the kidneys and heme goes to the kidneys, it causes severe kidney toxicity, so renal failure. I'm listing like 3 big things because obviously the person is going to feel crappy, nauseated, and running high fever. Does it make sense? Okay? That's transfusion reactions. That's just reminder. You can go back and refer to it. Now, hypersensitivity type 3. This is also called, so it's mediated by immune complexes. The great example of this disease is lupus. In lupus, your immune system, for some reason, starts to recognize one of the components of the basement membrane. And I can't tell you which component is that. The point is, your immune system produces antibodies. Antibodies that recognize proteins in the basement membrane. Does anyone remember where is the basement membrane? It separates two types of tissues. Huh? Which, it's not only there, you're right, it separates dermis and epidermis, so it's between which and which tissue? Epithelial, and what's dermis? What type of tissue? Type. There are four types, huh? Four type. Connective. Does that make sense? Connective. It separates epithelial tissue and connective tissue. Okay? Can you give me another example? Where is epithelial tissue? So, Hunter mentioned skin. Epidermis is epithelial tissue. Where else are you going to find epithelium? Respiratory tract. The entire digestive system. Blood vessels. Everywhere there is a lumen. Like, abrasion is going to be stratified squamous, okay, like in the mouth or in the skin, but it's going to be kidney tubules, it's going to be blood vessels, it's going to be digestive tract. So here what happens, epithelial cells of unknown kind are separated from the connective tissue by the basement membrane. Okay. Does that make sense so far? The picture and connective tissue is here. Antibodies that are produced, abnormal antibodies, I want to highlight, abnormal antibodies produced by your immune system interact with the proteins in the basement membrane, forming immune complexes. Antibodies by themselves, do they do anything? Do they kill? Do they destroy? Do they lyse? They don't. What do? They signal, they tag, they label. And in this case, they label your basement membrane for destruction. So immune system, for instance, macrophages, okay? Macrophages will migrate to the immune complex site and will start to phagocytose those immune complexes. Does that make sense? Antibodies mark your basement membrane as something that should be destroyed. And macrophages and T cells will destroy. Does that make sense? So pretty much you're screwed. What are going to be symptoms of lupus? Skin lesions, severe kidney dysfunction, mostly so think about this. Where's epithelium? Skin, lesions, kidneys, renal tubules, kidney dysfunction, blood vessels, sorry, inflammation. It's going to be constant inflammation of all blood vessels, which means thrombosis and hemorrhages. It's going to cause arthritis pain because the synovial membrane in the synovial joint, synovial cavity, will be inflamed as well, okay? So it will overproduce synovial fluid. It's going to cause pain and inflammation in the joints. So lupus is the chronic autoimmune disease that works through the, it's a type of sort of type 3 hypersensitivity. Does that make sense? What's going to be the treatment? Immunosuppressants. The most common sort of first choice immunosuppressant is, you can technically get the cream with it over the counter. Hydrocortisone, yes, steroids, yes. You can get it over the counter. We have now, I don't know about lupus, for rheumatoid arthritis we have some more specific drugs that are essentially antibodies against interferon. So they can recognize human interferon and not interferon, antibodies against certain cytokines and chemokines that can decrease the level of activation of your immune system, decrease the levels of inflammation. So they pretty much, those are advanced immunosuppressants. They're not going to cure lupus, but they're going to treat it. Of course, the downside of that is infection. Since you are immunosuppressed, you become more prone to any type of infection. That makes sense? Okay. Type 4. It's kind of exciting one. Type 4 hypersensitivity. So this one is T-cell mediated. So I'm going to do it using the example of TB test, right? So when, God forbid, you get exposed and infected, exposed to and infected by tuberculosis microbe, Mycobacteria tuberculosis. Okay, so this is going to be TB. Okay, the infection will lead to the cellular T-cell immunity. Does that make sense? So T-cells are presented with the antigen, first of all, and what is important, they form memory T-cells. We discussed it already. You should remember that. Does that make sense? So infection with Mycobacterium, you get a population of T-cells, a clone of T-cells that form a memory population, and say infection goes pretty much latent. You don't have active tuberculosis. Now, to check if you ever had tuberculosis in your life, if you ever had an active infection, if your immune system was exposed to Mycobacteria, what do doctors do? You get a TB shot. What's the TB shot? It's a protein of bacteria, Mycobacterium tuberculosis, gets injected how? Not under. Within. Intradermal injection. That's important. It has to go in the skin. Because there are special cells in the stratum spinosum. I know it takes you like, some of you it doesn't take long, but for most of you it takes like a year ago. Special immune cells in the stratum spinosum. Immune cells. The dude, his last name starts with L. Langerhans cells. Langerhans cells in the skin are dendritic cells, okay? So TB shot in the skin Langerhans cells which are dendritic cells present the antigen, and they present the antigen to those, so memory T cells recognize the antigen, present it to them, and start to proliferate, right? They start to multiplicate. Does it make sense? You follow me? So you have T cell response, which will involve two populations. To remember, two big types of T cells. The killers and the helpers, right? The killers and the helpers. Killers CD8, helpers CD4. What killers are going to do with your tissue where you have that antigen? You're going to kill it, yes. So you're going to start destroying the tissue. What helpers are going to do? They're going to help. They're going to show, right? They're going to help. So helper cells will activate macrophages that will migrate to the site of inflammation and will start to destroy tissue again. The tissue destruction and spilling of the plasma into the extracellular fluid, what's it going to look like if you had the TB before? It's bump. It's a big bump, right? You never had TB test? You had it, right? You never had reaction, meaning that you never were exposed to TB. If you were exposed, it becomes quite considerable bump. Does that make sense? Question, David. DC, dendritic cells. I'll write it down. Does it make sense? You see? So if you, now, since somebody just injected your skin with some kind of foreign substance, you're going to have reaction anyway. If you ever got TB test, you know that there's going to be a little bump, there's going to be a little redness, but there's a clinical criteria, the size, 5 millimeters, I think, and the elevation. So it has to be above the surface of the skin by a certain number of millimeters. Does that make sense? If it under these parameters, you clean. If it's above, you're not. Okay. The problem is that if you ever had a vaccine against TB, the test also comes out positive. And pretty much every person in the world will get this problem when tested for TB in the United States. So most European countries, African countries, South American countries, they vaccinate against TB when you're a child. So you really don't have an option. You're a couple days old. And then you have a chance to produce that reaction for the rest of your life. And a buddy of mine actually went into that. He was judged TB positive because he was vaccinated, but it was in States, so they put him on antibiotic regimen, despite the fact that chest x-ray was absolutely clean. He, smartass, started to drain him down the toilet. Well, there were smartasses too, so they started to take urine from him and test him for antibiotics. And about, it took the hospital 6 months to announce that he's clean. Yeah. And look, he was obviously from Ethiopia. He was so obviously from Ethiopia. He was born there, he was raised there. You could call, but nobody cared. The procedure is the procedure, okay? So for what do you have to know for hypersensitivities? Sorry. Type 1, the mechanism mediated by immunoglobulins A, how they attach to mast cells and cause degranulation. For type 2, transfusion reaction is an example that pretty much goes back to the blood groups. You have to be able to explain the concept of a blood group. Does that make sense? For type 3, immune complexes that are formed in a basement membrane are attacked by macrophages. And type 4, that it's T-cell mediated immunity, and during the type 4 hypersensitivity, T-cells proliferate because of the memory T-cells, the population that you had before. This type is sometimes called delayed. Why this type is delayed? Why? Because T-cells have to replicate. It takes time for the immune system to mount up the response. Delayed hypersensitivity, often called delayed hypersensitivity. Does that make sense? Okay, what's next on, that's weird, in our agenda? We have a couple of lovely things. Okay. Transplantation. You're definitely going to work with transplant patients. And you have to know the 4 types of transplants. You probably will deal with only 3rd type. So first type is what? Can you donate tissue to yourself? Yeah. Especially burn victims. When the grafts, skin grafts are taken from usually the back and moved to the burn site. Okay? This type is called autograft. Okay? That makes sense? If you have an identical twin, you should be faster than your identical twin. You should chain him or her to the basement, feed, at sleep, and use as the organ donor. Because this is, if you have a kidney failure, you cannot give yourself a kidney. You have only 2. One is failing, so usually both are failing, so it's kind of a problem. Having an identical twin, you can take organs from your twin. That's best possible situation, because identical twins are as genetically close as possible. They almost clones, especially in terms of major histocompatibility complexes. Okay? One is shaved. Okay? So that's going to be isograft. Identical twins. The most common type is allograft. Okay? You have 2 absolutely different people. Okay, and one is a donor, another one is a recipient. That applies to any family relations. Okay, mother, son, brother, another brother, if they're not identical, okay? Any type of, doesn't matter if your donor is your relative, or your donor is completely different person that you have no relation to. Okay, it's still considered to be an allograft. Examples are so numerous that pretty much every transplant is an allograft. Does that make sense? And the fourth type is xenograft. Well, since I can't, the only animal that I can draw is the mouse. Here's the mouse. I can't draw a pig. Usually it's pigs. Pigs or big apes or monkeys. Okay? So it's from animal to human. That's xenograft. Xeno stands for alien, foreign. Does that make sense? So what types of xenografts? I know actually one. Valves, heart valves, because there's little rejection associated with it. But obviously, trying to do the xenograft, like taking a heart, there were attempts. There were attempts of transplantation of organs from animals to humans. They failed, all of them, because there's too much difference. So what is the main problem in transplantation? Rejection. Why? Now, since we covered immunology, now you should know what is the mechanism. How does your immune system knows that, how does the immune system knows that the tissue that was transplanted is foreign? Which molecules? Huh? Not just antigens, there's special molecules. Well, antigens, but look, it's not just antigens. Major histocompatibility complex molecules present different antigens. They're different, okay? So when people are matched, one of the most important things to match is to match as close as possible the MHC molecules. There are, I don't know how many criteria are used now to match the donor and the recipient. And interestingly enough, how to say, it's not a donor that is picked for recipient, but it's the opposite way. Does that make sense? For instance, person dies in a car crash. God forbid, but person dies in a car crash, and the person has, on the driver's license, has organ donor. Okay? So, say, kidneys, liver, and heart are in a good shape, they're intact, or person after the crash, person is brain dead, which means it's a clinical death, but organs are maintained in vital stage. So what happens next? Quick typing. It can be done. Blood, first of all. Blood group is the first thing to type, and then plenty of other genetic markers. And when it is matched, when it is typed, it goes into the database. And then the closest recipients will be looked up. Does that make sense? Of course, there's a position in the list, all of that. But if you're on top of the list, but you're absolutely no match for the donor, you're not going to get organs because they're going to die. It's going to be a waste of tissue. There was a case when a donor was like in States and recipient was in UK. They flew the organ across Atlantic on a jet, the military jet. They had several hours, so it was a direct flight. So that's how it gets picked up. Now we get more and more successful, yes.
That's what I was going to ask, if like the whole donor list thing, is that like worldwide, basically? Like, how do they split that up?
I'm not sure. I'm not sure about the policy, really. It would be lovely that would be worldwide. let's speak reality. I don't think any potential recipient from Africa will trump a potential recipient from Saudi Arabia just because of money. Okay, they will buy the entire hospital, right? So that plays a role, and as far as I know, it's more of a national registry. For bone marrow, it's national registry, but sometimes, maybe if it's rare or something like that, it can be requested. So the problem is rejection, correct? How do we fight rejection, or how we do fight rejection? Huh? Antibodies is the most recent one. Usually various types of immunosuppressants. Okay? Cortisol is like to-go option. Okay? Now, what is the mechanism of rejection? If you think about it, if, let's say, red is the donor cell, right? So this is the donor. Let's say it's a kidney cell. Okay, donor cell. It has MHC on its surface, MHC class 1, and presents the own antigen, the normal antigen. And this, the black, is your cytotoxic lymphocyte, CD8 cell. Okay, recognizes MHC class 1, turns out to be foreign, starts to kill it. This is oversimplified idea, okay? But the point is that this rejection mechanism is mediated by your own T cells. Does that make sense? It's T cells that recognize MHC molecules on the surface of the transplant as foreign and start to attack the transplant. Does that make sense? Now I'm going to ask you another question. Imagine someone with, God forbid, leukemia. So, what we call incorrectly blood malignancy, which means, say, leukemia, overgrowth, overproliferation of white blood cells, right? So, how is usually leukemia treated? Bone marrow transplant. So you still transplant an organ, right? But it should be the organ that produces blood, so bone marrow. Now, can you just take bone marrow from one person and stick it into medullary cavity of another person? Okay, if person has a bad liver, can you just put the good liver next to it? No, you can't. You have to remove the bad one first, right? Right? So you have to remove the bone marrow, the bad bone marrow first. How do you do it? Oh, that will be quite a challenge. Radiation, you kill everything, right? Because it's cells. Essentially, bone marrow, the functional unit of bone marrow is the hematopoietic stem cells. So just irradiate the person, and hopefully, all bone marrow cells die. And then you put new bone marrow into the person's medullary cavity, and it starts to produce blood cells. Red blood cells, white blood cells. So far, so good. So this is recipient. That's bone. It's not a tooth. That's a bone. And here we got the donor bone marrow, okay, which then produces white blood cells. Okay, and these white blood cells go into the tissues, and they see, say, a liver. What's the problem here? Those white blood cells will recognize it as a foreign. They will recognize every cell in your body as foreign. Does that make sense? You got it? They're not your blood cells. So they're going to recognize every cell in your body as being foreign to them, and they will start to destroy every cell in your body. This is called graft versus host disease, or GVHD. It's a huge problem in the bone marrow transplantation, really big problem. You can imagine that the better the match, the lower the chances of graft versus host disease. That's why when you donate blood, I don't know about now, but I was asked at a certain point, can we put you on the bone marrow registry? List of potential donors. They can determine your antigenic groups based on analysis of the blood, and I am on the registry. So if there is a person who needs my bone marrow, I can be summoned into the hospital. They take my bone marrow, which as far as I know is an extremely painful procedure, and it will be used as the donor material. Does that make sense? So that actually really helps now that we have that big data. So those are two major side effects associated with transplantation: the GVHD, graft versus host disease, and the rejection. Okay? Essentially, in rejection, your body rejects the transplant. In GVHD, transplant rejects your body. It was one of the cases that I know of GVHD was when two engineers, Soviet engineers, got accidentally exposed to the gamma rays. They were fixing gamma ray gun in the production sterilizing unit, okay, and they fixed it, but it was on all the time. So they fixed it, and they were exposed to like lethal dose of gamma rays, not so lethal. So their bone marrow was completely destroyed, and to treat it, they got bone marrow transplant. It was 70s, so nothing was really known about the full compatibility. And for 2 months they were in perfect shape, and then they developed multiple organ failure. So they developed graft versus host disease. And 2 months after the transplant, they weren't treated. I mean, they got the transplant. They were perfect. They were awesome. They felt fantastic. And then when they accumulated enough T cells that came from somebody else, those T cells started to ruin their tissues, and they died eventually because it was full incompatibility. Okay. Another now we treat. We maintain transplants by immunosuppression, and many people have to go on immunosuppressive drugs for a lifetime. My wife's colleague, he's in remission from leukemia. He got bone marrow transplant. He's always on immunosuppressants. He takes them regularly. So if somebody sneezes in the lab, he goes home. He doesn't eat at the cafeteria because he can't trust people there. Okay, so he has his own lunch. I mean, he's not being like always in a mask or something, but he takes care of himself. Okay. Another problem is when you immunosuppress a patient, there can be an infection, not only coming from the outside, but for solid organ transplants like kidney or liver, it can come from kidney or liver. Okay, I mentioned to my micro class the case when several people got the organs from a person who had rabies, and the recipients were royally screwed up. By royally screwed up, I mean they all died, all the recipients. One of the major, if not the major cause of kidney transplant failure is cytomegalovirus. It is usually latent, so like 60% here have it. Okay, no symptoms. But when kidney from the positive donor is transplanted into the negative recipient, and recipient gets the immunosuppression, virus starts to replicate, causes inflammation, and surprisingly, it doesn't kill the kidney. It causes the stenosis of the renal artery. Inflammation narrows down the blood vessel. No blood flow, hypoxia of the transplanted kidney, failure. So it's pretty frequent, and rejection time is about 2 years for that. So after 2 years, you should be fine if you survive for 2 years. But it's kind of amazing. If you think about it, the first heart transplantation was what? 60s, I think? I think 60s. I don't remember. It's 60s, South Africa. And the first recipient lived like 9 days. And now people live for years. So we went far. Okay? I'm waiting for growing organs from the stem cells. Now, next thing that to talk about are immunodeficiencies. So think about this. We spoke about, if we speak about immunopathologies, we can speak about immune system being too active. That's hypersensitivity, autoimmune diseases, right? Or being too passive. That's immunodeficiency. So first of all, immunodeficiency can be acquired, right? It can be congenital. What does congenital mean? You're born with it, okay. And acquired means, yes, developed. That's important. So what types of acquired immunodeficiency can you name? What kind? What is the acquired immunodeficiency? That's great example, but not of immunodeficiency. That's actually that's autoimmune. That's hypersensitivity, and it involves type 2, 3, and 4. So it's a combination of hypersensitivity type 2 via immunoglobulins, immunoglobulin G type 3 through the immune complex formation, and type 4 through the T cells. So it's hyperactive, it's autoimmune. How your immune system per se, can be dampened. Stress, well, you can count it as temporary immunodeficiency, okay. Cancer, very good example. It can be a solid organ cancer, or it can be leukemia, okay. You may say, wait, in leukemia we produce a lot of white blood cells. Why your immunity is lower in leukemia? Because they're wrong. They're not correct white blood cells. Does that make sense? Okay, stress, cancer. I was expecting it first. HIV, AIDS. There's another infection that is acquired immunodeficiency that is transient, though. Transient means that you are immunodeficient for a considerable amount of time, and then you become normal. It's measles. It's rarely mentioned. Measles completely destroys your B cells. 6 months after the infection, patients are immunosuppressed, and pretty good immunosuppression. Okay, that's acquired. What about congenital? I'm going to give you a little heads up. We do not know of knocking out the entire innate immunity. Does that make sense? Do you see what I'm saying? So we don't know about any genetic conditions. They would leave person without complement, interferons, mechanisms of inflammatory response, macrophages, neutrophils. We don't know. Okay? So we're going to focus on adaptive. So you're going to tell me what two big mechanisms of immunodeficiency you can have if you talk about adaptive. What you can lack? Huh? T cells. Okay, you may not have T cells. Or say it out. Or B cells. Yeah, there are two mechanisms. No T cells, no B cells. So if you have no B cells, what does that mean? What do you not produce? Antibodies. It's called a gamma globulin emia, which means no gamma globulins in the blood. This is, compared to lack of T cells, I would consider it a little milder response because you can use artificial injectable IgG. Does that make sense? Okay. No T cells is called DiGeorge syndrome. What? I think there is. There's some funny Anglo-Saxon last name, I think, associated with B-cell deficiency. Like, why I say funny, there's a book, for instance, on human anatomy, whose author is Good Enough. I'm not kidding, it's the last name of the person, Good Enough. So, it's funny. Come on. Okay, so usually B-cell deficiency is milder than T-cell, because remember we talked about especially CD4 cells. They help B cells to become more active, macrophages to become more active, stimulate development of CD8 cells, and so on and so forth. So T-cell deficiency is really severe immunodeficiency. Okay, there are milder forms of both. For instance, person has B cells, but antibody production is deficient. So either they produced at the lower level or they have improper structure, okay? There are conditions like that. Same goes for T cells. So that's one condition, that's another condition. T cells, you have T cells, but no activation. So those four conditions that we know. So pretty much these two are slightly softer versions of DiGeorge syndrome or a gamma globulinemia. Does that make sense? I'm coming to the climax of that thing about immunodeficiencies. Is there a chance to not have both B and T cells? Yeah. So no B or and T cells is called SCID, which stands for severe combined immunodeficiency. Right? If you have heard the term boy in a bubble, Have you? That refers to the person with SCID. SCID usually is a SCID. These people have to live in sterile conditions. I know about 2 cases. Probably there are more. About 2 cases. 2 boys that were born with this condition. They both started living in pretty much sterile environment. The food was specially treated, sterilized. The medical personnel was wearing special protective PPE, personal protective equipment, to prevent potential transmission from them to the boy. Essentially in the bubble, not literally like in the glass chamber, but they have positive pressure room. Okay, so all air flows from them. Does that make sense? Then at some point, when they grew up enough, well, the first guy grew up enough. The second guy had a much sadder story. So the first guy grew up. He started to receive blood transfusions. Okay, white blood cells, immunoglobulins, everything. It was actually pretty good because his own immune system didn't interfere. And he lived on the blood transfusions for quite a long time. But every time somebody receives the blood transfusion, what happens to a little proportion of red blood cells? They die, right? They lyse. And when they lyse, what do they release? Huh? Iron, heme. What does it do to your kidneys? It kills them. So this guy died about the age of 30-something because of the renal failure, because of blood transfusions. Okay, but he lived for quite a long time. Second case is, in my opinion, much sadder. The family had the same situation, boy with SCID, and eventually they decided to go for a bone marrow transplant. That's an obvious treatment, right? You put somebody else's bone marrow with proper immune cells, okay? And the donor, the closest matching donor, was this boy's sister. Remember, the boy has no immunity, so he's ideally immunocompromised. They took bone marrow from his sister and put it into the boy, the recipient. He was well, I don't want to lie about his age. He was definitely above like 14. I don't remember how old he was. So they took the bone marrow from his sister and put it in the boy. It turned out his sister was positive for Epstein-Barr virus, which in healthy people causes mono. In immunocompromised, it destroys all epithelial tissue. Epithelial tissue, B cells, so the virus had a field day. There's no immunity there. And after the transplantation, the boy died pretty quickly because of systemic EBV infection. And the family wasn't, well, probably they were, I believe they were very sad. They decided to have another boy, another child, and they had another child, and that boy was also SCID. He died when he was 6 months. The doctor said, you shouldn't try anymore. And they tried, and the third attempt was successful. They've got a healthy boy. Based on the information that I've got, you said 2 cases of boys with SCID. The 6-month-old boy, well, the boy that died at 6 months, and the healthy boy. What type of inheritance this disease has? Recessive, 1. Yes, sex-linked or X-linked recessive. So this condition is in boys, okay? Again, can you get a girl with that condition? Yes, you have to mate the SCID boy and SCID carrying girl. And then you have a chance to get the SCID to grow. That makes sense? So what you have to know for immunodeficiency. You should be able to explain what SCID, like during SCID, the person doesn't have B cells, doesn't have T cells, doesn't have both, have low number of B or T cells. That makes sense? Just know that stuff. In D. George syndrome, A gamma globulinemia is kind of easy because if they have no immunoglobulins, it means they have no B cells, right? Understand what, I'll give you the list, which of this is acquired. Well, 1, 2, 3, all of the above. Okay, that makes sense? That's it. What I suggest we do now for the break